It's a great pleasure to be here sharing some of our thoughts on Theranostic-Guided Oncolytic Virotherapy. I know we get really great coverage today on the immuno-oncology aspect, but we would like to share with you some of our perspective on using Theranostics image-guided or soluble markers that we've been developing over the years at Mayo to guide our therapies. Before I start, I have a financial interest in the subject that I'm going to talk about. Myself at Mayo have equity in the two companies, and the virus is licensed to Virotherapy, and as Imanis is developing NIS technologies. So I think we are all quite familiar with oncolytic virus therapy. You know, the reason that we are all excited is the potential for its oncolytic phase. It's not just a gene vector. It delivers, the virus gets delivered by the bloodstream to the tumor, extravasates, infect tumor cells, and this replicative spread is the essential component of this oncolytic phase, where the virus progeny spreads into the surrounding tumor cells, and this cell killing and the inflammatory killing releases tumor antigens that will you know, nowadays they've given us this fancy thing that we can't point at all, which is very annoying to me, and did complain to them. But you have this inflammatory tumor cell killing, and your T cells and immune cells will go there and mop it up and present antigens, and therefore achieving your long-term anti-tumor control, and the patient should have a more favorable outcome. But there's a problem, and it's personal. It's personal because oncolytic therapy varies, and tumors vary in their susceptibility to viral therapy, or else you'll see tumors melt away in the patients that we treat. So there could be a pre-existing antiviral state. It could be then the robust innate immune defenses that come in to stop the viral infection and spread, or the tumor microenvironment being very hot will prevent the infection and the subsequent spread, or prevent the infiltration of T cells. So what we end up have to do is to do bigger trials in order to show this specific enhancement. We would need to treat more patients, and many of whom will not benefit. So what is the solution? And the obvious easy one is to try to identify susceptible tumors, and that's what we've been doing for many years, and many companies have sprung out doing PDX model technology, tumor biopsies, high throughput drug screening. And that's what we've done in our multiple myeloma trial using oncolytic measles virus, where we are able to take bone marrow aspirates, isolate the CD138 positive multiple myeloma cells through flow cytometry, and ex vivo infect them with a virus carrying a surrogate GFP protein. And here you can see patient 1 to 5, beautiful infection. All those big balls are syncytial formation due to the oncolytic spread and fusion of multiple cancer cells together, and that varies depending on susceptibility, intracellular susceptibility, or the extracellular entry through CD46 entry. However, the in vivo and in vitro susceptibility can also differ. And you can see here is a panel of murine cancer cell lines that we have taken. Vero African green monkey, the virus producer cells, LM1 mouse ovarian, EMT6 breast, ID8 ovarian, 5T-GM1 and MPC myeloma cells. And these are viral output assays that we've done, infected them with virus, calculated how much we put in and calculate how much we got out, and 24, 48, and 72 hours, you can see there is a lot of virus being produced. As a VSV, high progeny yield, you can actually get 10 to the 8 output in a very short period of time. We can also measure extensive cell killing by varying the MOI. At high MOI of 0.1, we can get almost all the cells killed. And these cell lines are highly susceptible to virus infection. But this is what happened when we put these cell lines in their syngeneic mouse models. On the left, you can see the MPC11 murine model, and we have given the mouse VSV GFP, and we measured by immunochemistry staining for the viral spread. The red shows us the immunostaining extensive viral spread in this highly susceptible tumor. But with LM1, that was producing more than 10 to the 6 viral particles over 24 hours, there was hardly any infection. Is it due to virus delivery? Well, I'm sure virus delivery matters, but if we were to look for viral RNA replication by qPCR for viral genomes in the tumor extracts, you can see 22 hours later, we get pretty decent viral particles that were delivered by the EPR effect to the tumors in black bars, but the amplification went robustly in the MPC11 over 24 hours, and you have dwindling over the other tumor models. The infection was suboptimal. Why is there this then restriction on spread of this virus? You could see the infectious foci that did not propagate very much further, and these were highly susceptible tumor cell lines in vitro. What we went on to do was then to test these tumors, extract it and took out also the cell line and perform various types of semi-quantitative RT-PCR for known antiviral genes. What we have found was that this tumor microenvironment, when you grow these tumors in the flank of these mice, it confers an antiviral state to the otherwise responsive tumor cells, such that if you were to look at some classical antiviral genes like the OAS2 and MX2 protein in the cell line LM1, there was barely any transcripts. However, in the tumor, you have now very high induction of these antiviral genes in a pre-existing antiviral state, even before it has seen virus. So now these cell lines become very protected against virus infection, and who's inducing that antiviral state? That could be a whole multitude of immune cells that could be cross-talking with the tumor cells. So then maybe the best solution that we could do instead of in vitro assays is to test the susceptibility of this intact tumor in situ in the body in its own environment. So what we're thinking is that viruses should be engineered to express reporter genes, and these reporter genes can be imageable genes, can be secreted genes, and that will give us the idea that maybe we could use an in vivo diagnostic test such that if we were to give the virus on day 1, test on day 2, and we can then decide to repeat those or not based on the test result or whatever is the preferred intervention that is supposed to synergize with your favorite compound. So one important reporter genes that we have been working on for a long time has always been the signature reporter gene in the Mayo Clinic studies is the sodium iodide symporter. It's a self-protein expressed in the thyroid and other parts of the body, including salivary glands, the stomach. And what it does normally was in the thyroid to concentrate iodine for the synthesis of thyroid hormones. When you use radioactive iodine or other anions that is compatible with the symporter that transports these anions into the cell, you now have a radioactive cell that now becomes a beacon. When you put the animal into a PET scanner or a SPECT scanner, you can identify the location of these NIS-expressing cells. So here shows you a beautiful image that's acquired by Lianwen Zhang in my lab, showing a bone marrow transplantation and engraftment of the cells, and you could see the homing niche exquisite into a mouse bone, and this is high-resolution PET-CT imaging in the animal. So what we have done over the years using measles virus as an example, put the NIS reporter gene into the genome of oncolytic measles virus by David Dingley at Mayo Clinic. And he was able to rescue the virus, and when we tested it in the farm tox testing, we showed that there is a dose-dependent anti-tumor activity in a CAS human myeloma model, and the picture on the right with the spinning images shows you in the same animal a flank tumor. This mouse given 1 dose of the measles NIS, you could see the areas of virus infection, and this is high-resolution SPECT-CT imaging, and what you are seeing, the hot spots in yellow and the blue colder are the areas of infected cells taking up NIS, and you can see there's robust expression even for quite a long time. This virus doesn't kill cells away so quickly. And in the patient, we are able to repeatedly see this if there is a good infection. Not all patients have a good infection, and this is a breast cancer tumor, a lymph node tumor of a patient who received a single intratumor injection of the measles virus, and it is the classical theranostic, where we apply imaging studies, I-123 for example. Pre-treatment, you can see the arrow pointing to a negative uptake at baseline, and day 3, the tumor turned really hot due to virus infection, and this virus infection clears as the virus-infected cells dies, or the infection gets cleared by the immune system. There's still some parts remaining, but largely it has gone away. And if you were to time it properly, maybe day 3 or day 8, you can add in a potentiating agent such as radioiodine that has beta-emitting properties that will kill off the cancer cells. The classical theranostic, that I-123, is being used, and with 131 in thyroid cancer therapy. So NIST imaging we have loved and developed for a long time, and now with the TFB F18 tetrafluoroborate tracer, that we have been able to show that it has much better imaging quality and sensitivity in our human patients, and we're excited to pursue it further as we dose escalate. So NIST imaging works great preclinically and clinically. However, that is never enough, isn't it? It's never enough for us to be useful as a diagnostic test, because we want to see earlier signals, lower signals, and quicker, and for less expensive. Because these diagnostic tests may not be sensitive enough to use low-dose virus. We only saw it in the myeloma measles trial at the highest dose level, where we see bright signals. Same with that breast cancer patient at the highest dose level. SPECT-CT or PET-CT is expensive depending on the institute and the area of coverage for the patient, whether you want to have systemic disease or just a local regional for sarcoma. It can cost $3,000 to $5,000, and it takes logistics and teams of radiologists and your nurse coordinators to set up the test. And not all sites, actually, when we do these tests, we always have done it at Mayo and we're familiar until when we launched the multi-center sites, we realized that it is a new way to use NIS imaging, and there's a lot of training to do to the radiologists despite their familiarity with thyroid uptake studies. So it is also subject to site interpretation of the relative uptake. Is it bright enough? Is it not too bright? So maybe soluble reporters are a much more sensitive and more quantitative way to go, and it will be easier and cheaper and more realistic to implement as an in vivo virus diagnostic. So in collaboration with Imanis Life Sciences, we have been also developing a beta-HCG reporter, and these are unpublished data that Imanis is happy to share with us, and it's their collaboration with Vyriad to develop an in vivo diagnostic for their VSV test article. We know a little bit about the beta-HCG for some of us because it's a highly sensitive biomarker of pregnancy. There's clinical assays available in clinics and hospitals. And what we have done was to put in the beta-HCG cDNA into the oncolytic virus to see is it possible to use beta-HCG as a biomarker of virus infection by a simple blood test or a urine test. And that is the virus construct that was being made. They have compared that this virus is able to grow well compared to VSV-GFP, robust titers of 10 to the 9 over time. That's a viral kinetics growth curve at low MOI. Importantly, there is robust beta-HCG gene expression in the supernatant of these infected cells. That's the biomarker is produced. And when injected intratumorally into a flank tumor, in the MPC tumor that's highly permissive, you can see that we can measure high levels of beta-HCG, about 40,000 picograms per mil in the blood, in the serum, or else we could also just take a very easy urine sample from the animal and quantitate it, and we can see that it's expressed, and it makes enough, and it's so sensitive that you can still detect it, because it may not be sensitive enough if your virus is not replicating. So what we next need to do is can it be useful as a predictive, a theranostic for us to test whether we can discriminate between susceptible or resistant tumors. So we had our models here, MPC11, the myeloma model that you have seen is highly permissive. CT26 that's sensitive is a colorectal murine cell line, sensitive to VSV, not as much as MPC11, and the resistant clone of CT26. And what we did was to implant the tumors, give a dose IT, and we did a blood test. The next slide shows us the viral titers that will tell us how permissive these tumors are and how much virus output did we get per gram of tissue. At MPC11, you can see 10 to the 6 to 10 to the 7 TCID recovered per milligram of tumor, infectious virus titer recovery, and CT26 mid-range, and then CT26R, which is quite resistant, barely any viral output at all. And you can see it correlates quite well with the beta-HCG, high levels of beta-HCG in the MPC model, and then the CT26 highly variable, which is very interesting because I think it may indicate that once there may be some threshold that it needs to get over, and then the CT26 resistant, we could not detect any beta-HCG. So that is the beta-HCG as a biomarker. Requires you to make a new construct, but when you next develop an oncolytic, it might be something to consider to put it in. But we also have another virus that we have been using and developing as a phase 1 clinical trial drug product, and that is the VSV interferon NIS that some of the our abstracts were presented earlier this morning, where the unexpected finding that beta interferon, human interferon beta may be useful as a biomarker of virus replication. As you know, vesicular stomatitis virus has broad tropism, is used to pseudotype VSV lentivectors. The virus itself is highly interferon sensitive. So to develop VSV as an oncolytic, strategies have included induction of interferon beta, for example, through mutex mutation or deletion of a single methionine residue 51, or encoding the interferon beta transgene itself. Voyager V1 is the code name for the VSV interferon NIS virus, and is potent and encodes the human interferon beta transgene and NIS reporter gene, and these are some of the functions that you've seen earlier this morning. VSV is suitable as a systemic therapy because of the low seroprevalence, but it also is a fast, potent virus and drives high levels of gene expression. The interferon beta transgene allows for us to control the tumor selectivity, but it itself is also a protein used in anti-cancer therapy because it has anti-proliferative and anti-angiogenic activities, but it's really kind of sexy in this immuno-oncology world because it also activates the immune parameters. But here we also add the fourth point that it is also a very sensitive biomarker of virus PD. The NIS you have seen before is an imaging transgene, but also allows you to use beta-emitting or alpha-emitting radiotracers for killing and achieving an abscopal effect in the patient. So this is what this virus does, the mechanism of action. After one intravenous delivery of Voyager V1, and thanks to Viret for sharing their slides with us, you can see that the flank tumor in the 5T-GM1 multiple myeloma in syngeneic mouse, virus seeds, you can see the staining done by Shruti Naik, red blood vessel CD31 staining, green is the VSV antigen at 6 hours, infection-centered, perivascular, that actually fuses to have infectious centers that coalesce to really cause a significant tumor damage and necrosis. The NIST imaging is exquisite, daily imaging of the same tumor. You can see how the infectious center seeds and spreads over time that fuses together. And at the bottom shows us the tumor response curves, where in the control, the tumor continues to grow, and in the mouse, the virus given mouse interferon beta virus, the tumor completely regress and doesn't regrow due to potentiation of the immune activation. This is what the interferon beta looks like in the MPC permissive tumor if you were to give this virus. There's a lot of virus replication and recovery in that tumor. On the left shows us immunostaining at different doses. You can see that high robust replication recovery at 2 to 4 days, and the corresponding interferon beta levels high peak at day 2 that rapidly declines as the viral infected cells dies off and then the virus infection clears away. And this is what it does when we give it to the VSV interferon virus given to canine with spontaneous tumor. Here are a collaboration with Amy LeBlanc at the U of Tennessee. Shruti Knight led that study in which pet dogs with cancer enroll on the veterinary clinical trials given the VSV virus, and you can see the human interferon beta that's encoded in the virals and not the canine interferon. You can measure good expression levels that decays over time as the virus-infected cells go away, dies off. But in some of these dogs, there is still persistent good viral expression in the tumors. What does it look like when you give it to a human? So thanks to Virotherapy for sharing their unpublished data here. This is their phase 1 trial in which they have demonstrated mechanism of action of their test article. And this is the result that I want to use to illustrate to you the potential of it using as a in vivo diagnostic, where we give the tumors, single injected tumor, despite the metastatic cancer, one tumor was injected by a virus one time, and we measured the interferon levels that is produced at day 2. You can see that each dot represents a single treated patient and the range of interferon levels that we saw in the blood. Perhaps we can see that at the low levels, 1 to 10 is low infection. These tumors are not selective, not permissive to the viral infection. And I forgot to add that the x-axis is dose response. So as you go towards the right, the doses increase. But despite low or high dose, there's a range. There's a scatter of patients that do not express very good gene expression, probably due to antiviral state. But there's a mid-class range where most cases they fall in. These patients express a variety of range of interferon beta levels from across the board of those range tested. And there are some patients, 2 of them in this case, that express significant level of viral gene expression, giving us a highly permissive indication of this tumor potential response to the virus. Often the question that's asked, are you just measuring an innate inflammatory response rather than actual viral gene expression? We do not think so because the data indicate otherwise. All across, we have seen in patients where the interferon beta levels continue to increase from baseline to 4 hours to 24 hours. These are 3 cases over time in an intravenous trial where we see an increase in the interferon beta levels and the other cytokines that are inflammatory acute response cytokines actually peak at 4 hours and go down to baseline levels, example interferon alpha in these 3 cases. So hopefully I have convinced you the importance of Theranostics-Guided Virotherapy, that monitoring the pharmacokinetics and pharmacodynamics of any drug product is essential to its development. And incorporating such markers into OV therapies have been very useful in validating mechanisms of actions and help in our dose escalation studies, because in many cases, for example, in the measles, we might have stopped dose escalation and not see a complete remission at our highest dose level as been reported earlier. In vivo diagnostics, however, could be challenging to implement, but it would definitely help us in our patient selection and perhaps perform better clinical trials at less expense and earlier and accelerate drug development. We anticipate that there will be fully FDA approved in vivo viral diagnostics in the future as we continue to develop it, and Imanis and Virotherapy are collaborating in that effort to try to push this concept forward. So with that, I would like to gratefully acknowledge all the collaborators whose data I have taken and used to make my talk exciting. I'm grateful to Mayo Clinic collaborators, Stephen Russell, Martha Lacey, Jamie Buckham-Gamas, who ran the IB trial, Stephen Brodsky, who read all the nuclear images, Shruti Naik, Lenwen Zhang, Beth Bruton, Nanda, and at Virotherapy to Alice Baxon, our CMO, and Imanis to Lakhana and her team for all the work. And last but not least, the patients and their families who have helped us to test a lot of our first-in-human studies. So thank you.
Okay. Good question. I'll shout. So So, does the virus, when you give it systemically, does it infect different mouse tissues, or it only infects the tumor cells?
Yeah, no, very good question. Is what are we seeing? Is it infection of tumor cells versus infection of normal cells? I think there will be some infection, but actually the proliferation will be in the tumor cells. So when you will to stain the liver and spleen, you can see a sporadic VSV infected cells, for example. The mouse, I can't test it with measles because it doesn't infect mouse. But in the VSV, you see sporadic single infected cells, for example, in the liver, but mainly it is really a homing. I think it's the extravasation plays an essential role. So I think you need imaging as well as soluble markers. So you could see where you are infecting.
I have a question.
Yes.
Oh, sorry, go ahead.
Oh, great talk. And follow up on the previous question, have you ever looked at the immune composition of the tumors after treatment with oncolytic viruses?
Yes, we have done that in the clinical trial. We have taken tumors before and after and subjected it in the nanostring analysis, the IO360 panel, looking for the tumor inflammation score. And we had 6 patients, 3 at the second dose level. And in one of the patients where actually she achieved stable disease with high interferon levels, the highest in that dose level, the inflammation score increased from 6 point something to 8 point something. Clearly a increase in the score, and you can see the tumor filled with immune cells like CD8, PD1, PD-L1 increases. But again, it's in between 3 patients, she had a really strong, robust response, and another patient, we didn't see any infection.
And also interferon beta itself, do you envision any side effects from increasing interferon beta in the blood, basically systemic increase in interferon beta, or?
Yeah, interferon beta has been used for a long time in the management of multiple sclerosis, so a lot is well known in the as a recombinant protein when you give it. So in some of these cases where there's long-term usage of this interferon beta, so sometimes you might get flu-like symptoms and aches and pains, as if you will have a virus infection. But if you were to drive interferon beta very high in the bloodstream, it will cause probably intravascular damage.
Thank you.
Now, Nori.
Just curious, just to follow up on Joe's question, if you took a non-replicating VSV expressing interferon beta, if you compared the level of interferon beta you get over a 2-day time course, let's say, it could act as a vector too, right?
Yes, it could. Yes, definitely. I haven't done the experiment, but I suspect in that MPC11. So it depends on what tumor models that you have used. I think if you use the MPC11, you'll see a high discrimination. If you were to give it to a B16, in which the virus barely infects, you'll probably see no difference. So again, it's different permissivity. Cool. That's it. Thank you very much.
Thank you.